It is the women of childbearing age who are the first true beneficiaries of a national family planning program. If under that program family planning services reach and help them, the delivery system has succeeded. If for whatever reason services do not reach them, the delivery system has failed. And in almost every corner of the world, it is already too late to risk failure. The factors which bear upon the establishment of a national program and the construction of a delivery system are many and various and occasionally delicate, for they deal, in the end, with that most sensitive of all social considerations, human sexuality. Between the decision to create a program and the formation of a services network lie a host of obstacles, human, mechanical, cultural, even spiritual. The basic problem seems simple enough. Provide to every fertile couple desiring it the means of spacing or limiting their families. The mechanism of accomplishing this is not simple, but success stories from many countries attest that it is possible. Dr. Benjamin Viel, Executive Director of the Western Hemisphere region of the International Planned Parenthood Federation, discusses with young members of a seminar group the options open to fertile couples today.
Dr. Viel, at the present time, which method of fertility control do you think is the most effective?
Well, you have to keep in mind that the perfect one hasn't been yet found. In general, all the methods available up to now could be divided into two main groups. The non-clinical methods, among them you have the abstinence, of course not very popular. You have the coitus interruptus that was practiced long ago in Europe. You have the mechanical barriers like the condom. You have the chemical barriers like the jellies. And you have the hormonal barriers, the so-called, commonly the pill, which is a very good method. And all of them has the biggest advantage that they do not require the intervention of a doctor and could be learned by the human couple out of very simple instructions. The clinical methods require the intervention of medical professionals or at least paramedical personnel properly trained. Among them you have the intrauterine devices, the interruption of pregnancy, and the surgical methods for sterilization, the so-called vasectomy among males and tubal ligation among the females. Which group of methods you should choose depends entirely on the type of community in which you are going to work. If there is a shortage of doctors, the problem is to maintain an adequate supply of the non-clinical methods. The clinical methods require the training of personnel. If a sufficient number of trained personnel are available, all of them could be used quite safely. In countries, especially the underdeveloped countries, where the medical profession is very scarce, I believe that the non-clinical method has a very important role.
Young women in a Trinidad health center learn about
Most
contraception.
of you all who are just married would like to have a baby, but you will say that you are not ready to have a baby yet. You would like to build a house, or maybe you would like to go out a bit. Now this is postponing pregnancy. Now some of you all who have had 6 or 7 babies, you might say, well, I've had enough, and this is what we call preventing pregnancy. Now, family planning is not only for postponing and preventing pregnancy, it's also for those who cannot have babies. Now, these are the different methods of contraceptive we have available at our clinic. Now, you have the IUD or the loop, the rubber, which the man uses. You have vaginal spermicide. You have foam in tablet, you have cream, you have the pill, you have different types of pill, and you have diaphragm.
Tell me, have you used these condoms before? The colored ones?
Once or twice.
Once or twice. The colored ones? Oh, very good. That's the plain one. Well, these are the colored ones. As you see,
Historically, one of the oldest contraceptive methods, the condom, has evolved dramatically in style and effectiveness in its long history, and has the considerable virtue of being available at low cost almost everywhere. The oral pill is the long-sought, almost infallible contraceptive of modern times. In its relatively short life, it has become the most popular, most effective, and most generally appropriate of all methods. Almost everywhere in the world, it is now dispensed by auxiliary health personnel. A pill program does demand strong, uninterrupted logistic support, but most national family planning programs acknowledge and accommodate themselves to this need. In areas where trained personnel is sufficient to the task, such clinical methods as the intrauterine device, requiring a lower degree of logistic support and less constant attention from its users, have earned wide acceptance.
That's a good girl.
The search for better IUDs, like the continuing search for better oral contraceptives, occupies the intense attention and massive research investment of both public and private sector agencies. Increasingly, for couples who already have the children they want, sterilization is being made available. An impressive number of international organizations are spending considerable resources in developing methods which will make female sterilizations as quick and uncomplicated as are vasectomies for males. Such procedures as laparoscopic tubal ligation have come very close to this ideal. The operation can be done in about 10 minutes, under mild anesthesia, through an abdominal incision so small that a Band-Aid is sufficient to cover it. A few hours of rest suffice for patient recovery. The key is the laparoscope, which permits the doctor to see directly inside the abdominal cavity as he separates and seals the tubes. Clearly, such procedures make heavy demands both on equipment budgets and medical personnel. Comparable ingenuity has gone into procedures for easier and safer termination of early pregnancy. An inexpensive kit for vacuum aspiration of uterine contents, and a technique for its use which can be easily taught, have gone a long way toward making the operation safe and simple.
After fixing the cannula onto the syringe, the valve is closed inside. So now the cannula is attached to the syringe. And then a vacuum is created by pulling the piston of the syringe backwards like this. up until the time that the shoulders come and rest on the flanges come and rest onto the shoulder. And within 20 seconds or so, on doing the rotatory motion, you can see that the menstrual fluid comes through the cannula and into the syringe.
A national program must first decide which methods to offer and the agency through which to offer them. Many countries have, like Costa Rica, elected to add their family planning delivery system to the government health organization. However, few government health organizations come anywhere near satisfying health needs. It is estimated that in less developed countries as a whole, not more than 10 to 15% of the population is served by official government health services. More often still, the government health network is too limited even to begin the task. To help make a start, Iran has called on the members of its National Service Corps, whose young men and women staff health outposts in remote communities. The young people come to be liked and trusted even by the elders of the village, and capitalize on that trust by persuading the women of this conservative world to begin to take some responsibility for their own destiny as wives and mothers. Familiar with local customs and attitudes, these young women can extend the reach of the health professional as no stranger could do. In a crowded urban district of Hong Kong, the Family Planning Association has established a uni-purpose clinic which is superficially quite different. In substance, it is similar in its adherence to the role of neighborhood clinic, offering information and service to women who learn to know and depend on the clinic staff. The role of the voluntary agency, once a national program is fully established, is often uncertain, but it has done important groundwork, and it would be ungrateful as well as impractical to overlook the fact. Experience indicates that such an agency can evolve most usefully into a training center, the operator of a model clinic, an agency for information and education, and a pioneer in testing innovative approaches in technology and operational patterns. Typical of a multi-purpose government clinic with a strong family planning element is this modest establishment in rural Philippines.
You notice that we have quite a heavy caseload in this clinic, and we average about 80 cases a day. And with one physician giving out family planning services direct to the clients, you can see the need for utilizing the paramedics in giving family planning service to the rural population. In the Rural Health Unit project of the Department of Health, we have around 5,000 paramedics, exclusive of about 1,500 doctors doing the direct services to the family planning clients. Now, these doctors constitute about 25% of the medical and paramedical personnel, as against 75% of the paramedics. Now, you can imagine how much augmentation we can have and how much more service we can deliver if we augment this staff by 75%. So I would venture to guess that we should be able to increase our number of acceptors by 50, as much as 70%.
One of the most successful sites for a family planning clinic is an urban hospital, particularly if public transportation facilities are adequate for travel from outlying areas, as they are in central Thailand. A large hospital not only has a broad range of facilities, but it usually enjoys the distinction which attaches to a reputation for authority and dependability. Chulalongkorn Hospital has been a pioneer of family planning efforts, and its present strength is in moving toward training of graduate medical students not only in the most modern techniques of maternal and child health care, but in all phases of family planning effort. Recently, Thai endeavors have concentrated upon the use of auxiliary health personnel to perform all but a few of the duties associated with contraceptive techniques. Particularly in developing countries, this may emerge as the central factor in expanding family planning delivery systems. The training of nurses and midwives as active technicians of family planning. Modern midwifery centers in the capitals and in upcountry stations concentrate primarily on the basic job of delivering healthy babies to healthy mothers.
pelvic cavity ตรงนี้เรียกว่า false pelvic ข้างล่างไปเรียก true pelvic นะพอหัวเด็กเนี่ยเข้าไปอยู่ใน true pelvic นะเราเรียกอะไร
Success in this field can have a strong secondary effect on the family planning record. By reducing infant mortality through improved birth techniques and infant care, the new midwives help to erase the ancient conviction that a woman must bear many babies to ensure that at least a few survive. Indigenous midwives may be wholly untrained in Western medicine, but otherwise deeply experienced. How can they, dependent for income on the babies they deliver, be induced to promote family planning? First, by being compensated for acceptors they bring into the program. Second, by learning the long-term value of helping their clients to be healthier and more prosperous through child spacing. The warmth and informality of these women is one reason why mothers cherish them, and one area in which better trained midwives may fall short.
I know that most of you...
The training of clinic personnel in the Philippines has recognized the crucial importance of this element and is using behavioral training techniques to teach self-confident young health personnel the possible error of their ways.
You know, in training, we have a little bit of role-playing. You have this in your basic training course, and you had this 2 or 3 days ago. This is called the role-playing technique. We do this for field motivators, social workers, and now we are going to do a little bit of it. I will pose as the nurse midwife, and maybe one of you could pose as the acceptor. Let's see now. Oh, Dr. Cortez, would you like to be the potential acceptor and help us with this little role-playing? Let's go.
Miss, I want to know something about family planning.
At this time of the day, it's 12:15. Our quitting time is at 12 noon. Come back tomorrow.
Oh, Miss, I can't come back tomorrow. Please help me.
Well, you see, I don't really care because I'm supposed to go home. I've been working so hard all morning and now you're here so very much late. Some other time you could come back, but be sure it's earlier.
A potential acceptor, treated brusquely or carelessly, may be lost to the program for all time. It is not enough that a clinic be convenient, well-equipped, well-staffed. It must offer acceptable service. It must permit a woman, however poor or ill-educated, to retain her dignity in this encounter. The success of this concentration on compassion and humanity in client encounters is reflected in a growing acceptor rate.
Now, when you go back to your respective clinics, think about this. And maybe you will be better prepared to serve your co-workers and to interact in that particular clinic. And in so doing, you will have a better relationship and you can exude warmth to your acceptors later on.
Ang family planning ay tumutulong sa atin, no?
Expansion and strengthening of a clinic network and improvement of clinic personnel performance go a long way toward reaching family planning service goals. But they will never be quite enough. A delivery system must avail itself of every possible opportunity to draw women into a program.
Nais kong ipaliwanag sa inyo ang mga paraan na ginagamit sa family planning.
Some of the greatest triumphs in family planning history have come when a program has made an intensive effort to persuade postpartum women to have IUDs inserted, to begin taking oral pills, or to use conventional contraceptives.
Ngayon, meron din tayong tinatawag na supot o condom.
Women who have just given birth seem susceptible to the suggestion that they should not do so soon again, particularly if they are recovering from the experience lying two in a bed in a humid maternity ward.
No, marereserba dyan. Kung minsan nabubutasan nga yan.
The search for targets of opportunity to sell family planning must be unremitting. Increasing numbers of factories are setting up consultation and supply stations to distribute information and condoms to their employees. The enlightened interest of an industry which is obliged to provide maternity help to its employees' families assuredly points toward the wisdom of promoting limitation or spacing of childbirth.
Good afternoon, Mrs. Thompson.
Afternoon, Doctor.
I see from the card here that you like to get some advice on some contraceptives.
Although the design of a delivery system normally concentrates upon the public sector, it is important to remember the unique strength of private medicine. Doctors who accept family planning principles, and there are a few who do not, are in a special position to help their patients adopt appropriate contraceptive methods, to follow up on their subsequent condition, and to provide the sort of individual attention which is hardly possible to an organization physician. Underlying all successful delivery systems must be a continuing form of public education. Historically, this has been the job of women volunteers, armed with a little knowledge and great enthusiasm. Women to reach women, wanting only to raise their sights and, perhaps, lift their hearts. And men to reach men. Whatever the cultural segregation in the society, both sexes must be reached and convinced. As delivery of services reaches farther into the rural areas, it is important to defuse in advance any explosion of conservative opposition, such as might be expected from the rural men of the Middle East. It is essential that they be given a broad choice. Even rhythm, withdrawal, and abstinence are better than nothing, since they may lead to a desire for more effective contraception. But a wise program will urge proved effective methods from the outset. Despite the importance of group efforts, there is still no substitute for individual attention where manpower resources permit it. An intensive course for augmenting development programs through paramilitary service gave this young woman basic health training and indoctrination in family planning services. Now she is en route from her rural clinic to a home visit. The woman she seeks has failed to keep a clinic appointment. Why? Is she having some difficulty with the method she has chosen? Should the clinic find another, more suitable method for her? Does she need medical or psychological support to continue as an acceptor? Follow-up visits are vital to the continuation of a program. A delivery system does not always travel a level road. Family planning program administrators, particularly in the more remote areas of developing regions, have learned that their clients must be sought out, sometimes with considerable effort. Many millions of fertile couples live and procreate far from the neighborhood of a clinic, well beyond the usual reach of any kind of health care. A delivery system can be simple or complex, but it must invariably be appropriate to the terrain and the culture in which it is established. In all discussion of motives and methods, of staff and structure, it is easy to forget the housekeeping factors, but it can be fatal to do so. Budgets must be realistic. Logistical systems must be appropriate to the budget and national priorities. A breakdown in the supply line of commodities can cause almost immediate collapse, sometimes of an entire program. A good general rule is, have 1 year's supply of all needed commodities on hand and another year's supply on order. Even with multiple donor agencies and the vagaries of government procurement policies, this should be an adequate safeguard against discontinuity. Even the most successful ongoing delivery system must be alert to opportunities for expansion, many of which can be found and are too often overlooked in the private sector. There have been solid results gained by the outright, practical use of commercial channels and promotion techniques to sell family planning. The Kinga program of Kenya is a vigorous example. Traveling out into rural areas which normally have limited contact with the world outside, the two small trucks, one for advance information and one for sales, are noisy and welcome arrivals. Kinga is the Swahili word for shield, and the aim of this project has been to place Kinga condoms in every tiny general store. Following a classic pattern of country huckstering, the condoms are exploited and sold at a low, subsidized price, as commercial companies sell soap and soft drinks. The Kinga information officer is prepared not only to show condoms, but to discuss family planning in general and to answer questions. The Kinga men know the farmer's reluctance to go to a clinic for a contraceptive, even when he accepts the idea. But he is willing to go to the local store, where he can retain his freedom of choice, his dignity, his sense that he is in control of his own affairs. The delivery system has reached him. Its effects will reach his wife and his children. The delivery system of a national family planning program is a road which reaches out to give a childbearing woman, her man, and her children a way to go forward, a road whose construction and maintenance are central to the ultimate success of a program.